everyone. My name is Dr. Waqas Tahir. By background, I'm a GP working in primary care, but I'm also the ICS diabetes lead for West Yorkshire. And here as a capacity, I'm also Yorkshire Numbers clinical diabetes lead for diabetes development programs and support in primary care, and also have numerous roles across both primary care and nationally. And it's a great pleasure to be here with you to talk about some of the priorities that we have, particularly around diabetes across our region, some of the perhaps the challenges that we've been facing through COVID, the fantastic work that we've done and are currently doing, and also a sort of step or a bit of a vision of the future. Where are we going? What perhaps we will see, and how we can tackle some of those problems, barriers, or variants in care that we see. So just to begin with, I'm going to take us all the way back and just do a really top line in terms of why diabetes is still one of the highest priorities, both across our region and also within the NHS. Now, managing the growing incidence of diabetes in England, it is set to be one of the major clinical challenges of the 21st century. We know that currently over 3 million people are living with diabetes in England, and the estimates suggest that this number is expected to rise to about 4.2 million by 2030. And if we think of that, that almost means that it will affect almost 9% of the population. So around 1 in 10 people will have diabetes. That is huge. And it is also estimated that around 5 million people in England are at risk of developing type 2 diabetes, so the non-diabetic hyperglycemia group that we see. The NHS long-term plan, it sets out a range of actions that the NHS is taking to reduce variation in both access to services and patient outcomes, but also to improve the quality of treatment and outcomes for people living with type 1 or type 2 diabetes. Now, over the years, you might have seen various programs through the COVID years, just starting pre-COVID around about 2018 and up until now. So there has been various pockets of transformation funding nationally as well as regionally to support projects from individual integrated care systems or ICSs to address these problems that we see across diabetes care delivery, to reduce variation in access to services, to improve the outcomes for people living with diabetes. And it has focused up until now on 4 evidence-based intervention areas. Firstly, around improving or ensuring access to specialist multidisciplinary foot care teams with an aim to reduce amputations. Secondly, again, from a hospital point of view, to ensure that patients have access to diabetes inpatient specialist nursing teams to improve the quality of care that they seek and they get during a hospital admission. And thirdly, more of a focus on primary care and across PCNs, practices and systems, is to reduce the variation in the achievement of those 3 NICE recommended treatment targets: HbA1c less than 58, cholesterol less than 5 or 4 in some instances, and a blood pressure target, which we have is around about 130 or 80 for both adults as well as children. And fourth, but not least, is how we both support and encourage our patients to attend structured education, but also expanding the provision of structured education. So not just looking at face-to-face sessions, but also including digital options, a menu of different options to better support, better educate, and better equip our patients around self-management. Another strategy that has threaded through over the last few years has been a renewed focus on preventative strategies across the NHS and diabetes. So you may have come across the Diabetes Digital Weight Management Programme. Across our regions, we have now seen the low-calorie diet, as well as the ongoing and very successful National Diabetes Prevention Programme. And we all have to thank each other as clinicians for showing tremendous effort in supporting these programs, again, yielding fantastic results, both in terms of weight loss and improvement in outcomes. So that's a little bit about where we are now. Let's have a look where perhaps we are heading, both within the NHS around diabetes, but more importantly across our region. So moving forward, the focus is around supporting ICB clinical leadership. Now, we have resource allocated which is really important, to continue to ensure that ICBs, or integrated care boards and systems, have strategic leadership for diabetes. We need us to take responsibility for embedding evidence-based best practice, but more importantly, to drive what you are all here today to do, which is to share learnings, to share solutions, to share different processes, different ways of successful strategies in improving both care processes, treatment targets, or even types of treatment across your diabetes populations. And a lot of it, as you'll find through the afternoon, the premise is around driving data-led improvement. So I hope you'll have a brilliant afternoon looking at all of those fantastic packs that have been designed for you. The direction of travel is to support the following areas across our regions. The Diabetes Prevention Programme. It is essential for us, systems, places, PCNs, GPs, to continue to review our data and work with our providers to address unwarranted variation, but more importantly, to really reduce inequalities in referral, uptake, and health outcomes. Secondly, as you're already aware, we already have active the low-calorie diet across our regions. And I'm pleased to say that all 4 ICBs within the North Eastern Yorkshire region have access to this programme and are at different stages of implementation. Third, we mustn't forget, we still have a renewed focus on the 3 treatment targets and the diabetes care processes. We have done a fantastic job in this post-COVID recovery side of things, but there is still a lot to do and still a long way to go. And our efforts should still continue to ensure that more people receive all NICE recommended diabetes care processes annually. And evidence has shown that care process delivery is associated with reduced mortality, death, emergency admissions, foot amputations, and diabetic retinopathy. So again, from a clinical standpoint of view, it's really important to ensure that we continue and progress all of those fantastic processes and activities that we are currently doing across primary care. Structured education. Now, despite our efforts, we know and we acknowledge that patients and that people living with diabetes often either struggle, find it difficult, or perhaps just don't engage with the offer that we have locally. Now, to supplement and complement this, there are also some nationally commissioned offers available, including My Type 1 Diabetes for people living with Type 1 diabetes, the Healthy Living for People Living with Type 2 Diabetes app and platform, as well as DigiBeat, which is an application or platform for children and young adults with diabetes. So again, encouraging a vast menu of both digital as well as locally commissioned activities and structured education courses and programs for our population. And again, the focus still remains and around multidisciplinary foot care teams as well as diabetes inpatient specialist nurses. So again, that's just to progress and maintain those services within hospitals and communities. The newer elements are perhaps how we support areas to continue with continuous glucose monitoring, particularly for pregnant women with type 1 diabetes. And we need to ensure that all of our women with type 1 diabetes who are pregnant continue to receive continuous glucose monitoring in line with NICE guidance NG17. And as you'll find across over the next 6 to 12 months, the criteria has expanded and there will be a focus not just on type 1 diabetes in pregnant women, but type 1 diabetes in general, but also type 2 diabetes and other specific cohorts, including learning disabilities and people with severe mental illness. I'm pleased to say that particularly across our region, we also have support, and there is also a specific regional scheme that is available in Hull and East Riding that looks at type 1 patients with type 1 diabetes, people living with type 1 diabetes and disordered eating. So that would be interesting to see how that plans out. And we see that there is some encouraging early data to highlight its success. And then we have transition services. So that's the gap between pediatric teams and adult diabetes care. So how we bridge that gap is through pilots. And one of those pilots is called the Children and Young Adult with Diabetes pilot. And across the northeastern Yorkshire region, this is relevant particularly to the northeastern North Cumbria ICS at the moment. So that's a little bit about the priorities, both within the NHS, within the National Diabetes Programme, what they mean for us across the North Eastern Yorkshire region, and also particularly around Humber and North Yorkshire as an ICS. And again, you can see that there is a breadth of different programmes targeting primary care, community services, different types of cohort of people with diabetes, as well as some hospital services. So we all need to work together to achieve all of those outcomes. The second bit, which I would like to talk about now, is just around how fantastic you've all done in improving both the quality and the quantity of care that people across the regions receive. So this will be a little bit around data. So just to give you all a snapshot, if we look at North East and Yorkshire as a wider region, we are still recovering in the completion of all 8 care processes for both type 1 and type 2 diabetes, but we're not yet back to pre-COVID levels. So although we're nearly there, we're just not back to pre-COVID levels. So again, please continue the fantastic work that we're doing across predominantly primary care, I'm going to say. If we look particularly across the Humber and Yorkshire region, Humber and North Yorkshire as well as West Yorkshire, and we're still recovering, and we're again not back to these pre-COVID levels for completion of the 8 care processes. However, the quarterly data that we see regionally and nationally, it is really, really encouraging, because across both regions we have seen that we have completed a higher percentage in 2022 compared to the same period in 2021. And we're above the England completion percentage as well. So that's encouraging for us as well. One of the things that has is really obvious that we see is a significant improvement between 2020, if we look at COVID years, and 2021 and 2022. But yet we're still to achieve values and rates of processes, as well as 3 treatment targets back to pre-COVID levels. Another interesting finding that we see is particularly relevant to the Humber, North Yorkshire and West Yorkshire regions, that we find that these are most affected by deprivation, where there is at least one place in each ICB where we find that it is significantly more likely for their patients, if they have a low IMD score or they have lower levels of deprivation, that they receive higher levels of 8 care processes than those who live in the most deprived areas as compared to the English average. So what we mean by that is that there is probably too big a gulf between different deprivation indexes or scores that we see. So those in the most deprived areas are receiving far fewer care processes than those in the least deprived areas. And we need to somehow bridge that gap and support different people across different health inequalities, whether that is deprivation, socioeconomic deprivation, language barriers, ethnicity, harder to reach communities, traveller communities, etc. But we need to address some of these inequalities that exist there. Now, just honing a bit back to Humber and North Yorkshire, again, fantastic job in terms of improvement in 8 care processes, but we still need to recover. We still are in this recovery phase, and we're still under the pre-COVID levels. Some of the interesting data trends that we did see and that we have noticed is that all places are above the England average for blood pressure. So well done, brilliant, but we're slightly below on one of the areas, which was around foot checks. So again, it might be something that we need to think about. And then there were 1 or 2 areas that we found that were below England for at least 5 of the 8 care processes. So a lot of the data as a top level looks very, very encouraging, and we're tracking national average, and there are huge strides that across our regions that we have made, and particularly successes in terms of improvements in blood pressure, not only checks but also in terms of a treatment target, and that's fantastic across our region. But equally we see a slight widening gap of health inequalities that we need to address, and particularly I think 1 or 2 areas where we found, I think it was Hull and North links, places where we understand the significant levels of deprivation. That often is a big challenge and barrier in improving diabetes care across your region and across those places. But that's where we see those huge variants. And again, it's just something in terms of the development and redesign of services and improvement of services that I hope you have conversations this afternoon just to support different practices and share a lot of those good practices across your areas. The last thing that I would highlight on a very positive note is that, like I said, is blood pressure fantastic. We're doing really well across Humber and North Yorkshire. But some of the easier things, perhaps, where we could really quickly improve on was around BMI, so BMI measurements, and smoking. So looking at some of the data, these are really easy things to capture. We found that these were the most common individual care processes where we were perhaps below the England average. So again, a really easy, quick fix is just probably putting those things at the forefront of our mind. And I'm sure you'll go into depth on a lot of those interesting conversations and shared learnings amongst your colleagues this afternoon. And lastly, it brings me on to one of the solutions, I'm going to say. So we've, in a way, taken us all through this journey in terms of the priorities that we see across the NHS within diabetes, what perhaps is expected of us, what are these different programs, what the data is telling us that there is a variance across that. So we know the road, we know where we want to go. How are we going to get there? And that's where we have some of these support tools. So some risk stratification tools, as well as other support that is available to us across our regions. One of the biggest asks for ICSs, PCNs, practices, and diabetes services is to restore the identification, monitoring, and management of diabetes to pre-pandemic levels, particularly prioritizing those that are at the greatest risk of both deterioration or complications. So we know that the National Diabetes Audit data that explains to us perhaps what areas we need to focus on, and also allows us to ensure an equitable recovery. And also we have a data recovery dashboard, which also shows the extent of the decline of care processes during COVID-19. But in addition to that, one of the areas where we felt there was a gap was around risk stratification dashboards. So this was something that we thought we could support primary care with. As a result of that, through the Yorkshire and Humber Diabetes Clinical Networks, I've been able to review almost all the best available diabetes risk stratification tools that we have at our disposal in primary care. And we've created a support tool guide, particularly for primary care, to support us in optimizing diabetes care delivery, resulting in improved patient outcomes. And the idea being is that we want really simple, easy to use tools that don't take too long to embed in our systems, that can either visually give us a really good user experience and tell us perhaps which patients or which cohorts or how we address different outcomes within our clinical teams. So one of the ways that we've used that across our PCN, so I'm one of, I think, 21 partners across a very large partnership and PCN, is where all of diabetes care delivery, we have a wider diabetes team, including GPs, DSN, practice nurses, pharmacists, HCs, and different patients based on their complexity, the patient needs, the skill set of our workforce. We try to match them up. So the idea being is that we can create smaller areas or smaller diabetes care packages that are very bespoke for different people that we deal with. So specifically around people are either are diet controlled on 1 tablet, 2 tablets, monotherapy, dual therapy, insulin, complicated insulin, or type 1 diabetes or complex comorbidities. So you can see the breadth of different diabetes care, and then we've matched different workloads or insight bundles to different clinicians based on their expertise within our system. So I would definitely recommend you have a look at these diabetes, the risk stratification tool, and where we've looked at various tools, including some of the searches that we've created within Affinity Partnership. These are relevant only to System 1 users because we're based in System 1. We've then looked at the Grasp DM tool, which is based in Nottingham, previously called Primus, and one of the brilliant ones which we really like and which is spread across the country is called the Palm Diabetes tool. So we know that up until now, latest figures tell us that about 1,000 practices have used this tool and are currently using it across the country, which is fantastic. And the other two tools we have is the Roche Diabetes Care Platform, which is very specific if you have patients or specific cohorts, particularly across the PCN or across systems that are on injectables, particularly insulin. So it gives us very different, wonderful insights in terms of how we can improve and make our consultations effective and efficient. And last but not least, we have the UCL searches, where it just basically truncates your diabetes population, particularly into red, amber, green RAG system, and predominantly around the risk of deterioration of COVID-19 or complications. So I think it was more of a really good COVID-19 recovery tool, perhaps less relevant in terms of if we have higher levels of ethnicity or multi-ethnic populations, as well as diverse or socio-economically deprived populations, as well as populations that have got high cardiovascular multimorbidity, because any of those risk factors would put everyone in the high risk group. So it therefore defeats the purpose of having a rank system around it. But otherwise, it's a really, really good tool if those challenges don't apply to your population. So that's just a quick run through of where we are, where we need to go, some support tools that we have at our disposal. And sorry I couldn't be there, but hope you all have a wonderful afternoon.